Hi, Theresa.
Hi, Rachel. Um, Hello, everyone. I am the lucky author who gets to talk to Rachel Jones about her new book, which I will show you with all my Post-it notes in it. That's how amazing it is. So Rachel's a journalist. She wrote this wonderful book called Grief on the Front Lines, Reckoning with Trauma, Grief, and Humanities and Modern Medicine Perspectives from Healthcare Workers. She has reported in Venezuela, is that correct?
hmm
Yeah. And then has been writing for a small organization that works on end of life care. And I think she's going to introduce me, and then I'm going to ask my first question, which is what got you to write this book? So
Thanks, Theresa. So I'm very honored to be here with Theresa Brown, whose third book is Healing When a Nurse Becomes a Patient. It's a wonderful book, and also best-selling author of The Shift, which gave me a lot of insight into what it's like to be a nurse in today's world. So yeah, I guess I would start by saying that I got into writing this book because, as Theresa mentioned, I was writing for Seven Ponds, which is a small website about end-of-life issues. And I became interested in that because I just always kind of have been, but then also because we have such a societal avoidance of aging and death, and it's something that we all go through. So when I saw an opportunity to write something in that field, I jumped on it. And I just found it fascinating. There's so much that I didn't know and still don't know. But I wrote an article for them about how clinicians handle the trauma of code blues. So for those who don't know, cardiac or respiratory resuscitation in hospitals and other areas of healthcare. And I had no idea how violent these could be and how traumatic they could be for the clinicians working in these areas. So I just found it really fascinating. So many of the people I spoke to were really grateful to be able to talk about the emotional aspect of their work. And I just kind of thought that was that. The article was written, and then Shana, my editor at North Atlantic Books, reached out and asked me if I wanted to do a book. So I thought about it and I thought, yeah, it's really important. It seemed really to mean a lot to the people that I spoke to. And so it felt needed. So that's why I decided to go with it.
oh, that's great. And I would say the truest answer to how do people deal with codes is badly. And that so often the feelings that come up are not acknowledged as you talk about. But I also would love you to say, what was it like to have decided to write this book? And then all of a sudden, we're in the middle of a pandemic, healthcare workers are getting slammed with overwork, with short staffing, with fear of catching this disease that no one knows anything about.
Yeah, it was a really interesting time. I think in the book I called it surreal. And I was actually in India. So I was in India when COVID started, and I ended up kind of
Wow.
getting stuck there actually. But it worked out well because I was kind of holed up mostly in this apartment in Chennai, where the family just brought me my meals and I would go for walks every day. And so it was kind of a little kind of writing hermitage in a weird way. Um, so I would be speaking to these healthcare workers on Zoom and by phone. And initially, it was hard to get people once the pandemic started because everyone was so busy and nobody knew what was happening. So there was definitely a gap there where I was like, I don't know if I can meet my deadlines
Yeah.
because this is not a great time. And all of my emails listing interviews were like, I'm so sorry about what you're going through. And I understand if you don't have time. But yeah, also once people did feel a little bit more like they had time to speak to me, they were really grateful, I think, just to be able to talk about what they've been going through and have the opportunity to share that with somebody who was going to be writing something in that area. So I think all of them made time, even when they didn't have it, because they felt like it was needed. So
Oh, that's great. Yeah, I can imagine it was challenging at first, but then I'm sure people felt so relieved to have someone to talk to about what they were going through. And I'd
mhm.
like to pull that idea through to one of the really, really important points you raise in the book. And there are so many important points about healthcare workers and how we're acculturated to not acknowledge grief and sadness. One of the really important threads is this real stigma in healthcare against getting any kind of mental health treatment. I mean, even to the point for physicians, it can affect their licenses, which is not true of nurses, at least as far as I know. So, I mean, there are so many angles to take to attacking that question, but I would love to just have you riff on that, what you found out, what you think would be great.
Yeah, well, I'll just say on a personal level, to me, that was the single most shocking thing that I learned in doing this research, because just as a normal person, I've been in therapy off and on for like 10 years. I've been taking an antidepressant since November, and I don't feel like any of that makes me weak or like, if anything, it makes me more open-hearted and more functional. So to read these clinician stories and what they have to face in obtaining mental health care when they are confronted with much worse things than I am, such as, horrific motor vehicle accidents and the trauma that results, or gunshot wounds, or people dying. It just was very, very shocking to me on that personal level. So there was that. And then to learn how systemically they're barred from accessing care was just, very shocking. And of course, it varies a lot, state by state and institution by institution. Some are more open to mental health care than others. But even those that are open, there's still the fear resulting from the overall stigma and the overall potential for licensure repercussions. So depending on the state, medical boards can ask more or less invasive questions about the state of a clinician's mental health and can make judgments based on that. I learned about physician health programs, which are controversial, and I didn't do a very deep dive into them. Other people have done that, and some of the things I've read have been very concerning. But any body that has that much power and so little accountability or oversight as to how they're managing their patients who are physicians is very disturbing to me. So I think there's, very, very real barriers to obtaining mental health care. And then beyond that, even when those barriers aren't there, just the fear of what might happen, whether or not it's based in reality which often it is, it's just very difficult for clinicians to access healthcare. I think there was one study cited in the book that said like 45% of emergency physicians wouldn't seek mental health care even though they felt they needed it for fear of repercussions. So that's huge. Yeah.
Yeah, I know during COVID, there was a real sea change among nurses that nurses were talking about. Oh, sorry, that's my dog. Nurses were talking about needing mental health care and actually seeing therapists. And then there were whole floors where nurses were saying, well, my therapist says, which is huge for nursing, and suggests to me that we don't have those same institutional barriers. But it's also so interesting because if you had a physician who had a broken leg and just said, no, I'm not going to treat that, or cancer, or anything, right, it would be like, what? That's first of all, you can't work like that. And yet the stigma against mental health care is, it's not just unspoken, it's systemic. It's part of the whole structure of medicine and medical training to some extent. And you and I communicated some about this. So for my book about my breast cancer diagnosis, that was a moment when I realized, oh my God, I'm not invulnerable. People in healthcare tend to think we are invulnerable. And I think partly because that's how we're able to do the job, to work for 12 hours, which becomes 13 hours without having lunch, without having breaks, to do it the next day, to face death and projectile vomiting and, all the things that go with the job, and keep doing it, we do think, well, I can't get sick. I can't have anything wrong with me. And so to have that lie I was telling myself basically be broken down was this profound experience. And it's part of where I think your book is so important, because it says, hey, we're all human, hello. None of us is super. And maybe just talk a little bit about that. You say several times that clinicians are taught to depersonalize or dehumanize patients as a way of keeping their distance, but paradoxically, that can also lead to burnout, right?
Right. And I think, it's all tied together, this whole sort of concept of stoicism or mental health care being weak, or like you say, this need to depersonalize patients. I feel like it's all kind of inherited with this white male, almost militaristic structure that medicine has been for so long, especially for doctors, but just as an institution. And so, I think that it's kind of outdated and I don't think it ever did work, but it clearly doesn't now. And especially since the pandemic, that's been pretty much widely shown, I think. But in terms of vulnerability and connecting with patients, I feel like that's like the single thing I heard the most often from clinicians was, I want more time to connect with my patients. I hate feeling like I'm on this assembly line and people are just, being kind of shipped through, and I don't really have that much impact, or I can't actually help them in the way that I was trained to or that I want to. And so just even having that time and that capability, I think, would be a huge boon to reducing burnout and reducing the distress that people feel, the moral distress and all the other kinds of stress that they feel. Because even if you have a bad outcome and a patient dies, at least if you feel like you provided appropriate care, you're not going to have that extra burden. And that was something that struck me about your book too, was the vulnerability that you just spoke about, but then also the fact that you decided to write about it. And I love that quote. I'm just going to read it really quick, but you said, I disclose medical details about my life to show what I learned from having cancer, but it makes me feel exposed as if my story comes in a string bikini top. And I thought that was such a wonderful image, first of all, and it was just so brave of you to, write the book anyway. So I'm just interested in hearing about where that bravery came from and what you most wanted to convey through your story.
Oh, thank you. And what I want to convey is such a compliment, that's with an E, but maybe also an I, to your book and what you explore. So I was diagnosed with breast cancer in fall of 2017. Terrifying, very scary, very sad, everything you would expect. But I thought, okay, this is going to be all right in terms of my care. Somebody's going to hold this for me. They're going to organize things. I was diagnosed, I was part of a study that did mammography and ultrasound. So I was diagnosed with an ultrasound. Then they got an extra mammogram. I talked to the radiologist. She showed me the images and she said, you won't leave today without an appointment for a biopsy. And if people listening don't know this, a scan can never definitively tell you whether you have cancer. You have to actually look at that tissue under a microscope, which means somehow someone has to get that tissue out of your body, right? I realize I've been using like biopsy, minimally invasive. No, someone takes a piece of your body out of your body and then they look at it. So, okay, now I'm done with all that. I'm going to go and schedule the biopsy. And there I was with streaks of tears on my face. It really was the worst day of my life. And I sat there and I sat there and no one came. And finally, a receptionist came by and said, "Oh, she leaves at 3. You just missed her." And I really seriously wanted to hurt that person, which is not a feeling I have. Like, I just don't get that feeling. And I had other feelings like that too when people were, not just not able to help me, but kind of thoughtless, dismissive. And that shocked me because I knew there were problems in the healthcare system, but I thought, well, all of us work so hard, we make up for them. And it's not true. If you're so afraid of your diagnosis, and I had what turned out to be a small tumor, it was very slow growing, and I was still terrified. You're so afraid, and the feeling is kind of, yeah, you are just another number on the assembly line. There's not going to be compassion. There's no one looking out for me. So that's what got me to write my book. And your book is so great because it's really looking at the flip side of that. I mean, in my book, I also look back at times when I was an oncology nurse and a hospice nurse, things I didn't understand about what my patients were going through, my own difficulty dealing with a very angry patient. What you're showing is, everyone working in the system pretty much wants to do well and is not able to. And it's really kind of eating people alive, from the inside. And so I wanted to say, look, we are failing patients in this fundamental way. And you're saying, yeah, and we're also failing clinicians. And then we saw that during COVID. So maybe it'd be great to give people listening the big picture and just talk about burnout or moral distress or compassion fatigue, these sort of, not to differentiate those terms, but to talk about, what are we dealing with? Like, I don't think people understand that the physician suicide rate is twice that of the general population. Um, that is not right. And so give us a picture of what you saw when you started to look into research.
Yeah, it was disturbing, and I frankly did not know either that things were as bad as they were. But yeah, as you mentioned, the suicide rate for physicians is double that of the general population. That for nurses and EMTs is higher, for sure. And this sort of systemic issues that occur, begin in medical training and in nursing school, where people are hazed, they're expected to adhere to really ridiculous work schedules and hours. There's this sort of militaristic attitude, where they're expected to give up sleep and food and just basically, the idea of self-care is not even something you can approach at that point because you're just trying to survive. And even after medical school, the whole system is just set up in such a way that people aren't valued in the ways that are significant. I heard over and over about these, pizza parties that people would get and that were supposed to be make up for all the other issues, which are huge. There's widespread bullying happening within healthcare systems, whether among nurses or among from physicians toward nurses or in all these various ways. There's workplace violence that has been rising steadily for a very long time. We just saw the most recent shooting in Tulsa at the hospital there. But that's not, that's happened elsewhere, but then there's also just the day-to-day being punched by people with psychiatric problems in the ER, or somebody with dementia, slapping somebody, or, I had some stories in there of clinicians who said they were body slammed or their colleagues were body slammed into the floor or the wall. So these are really difficult and violent environments. And then just the trauma that comes with death and code blues and the lack of ability to process all of that is stuck there in the middle of this really challenging environment already. So there just isn't, and I feel like administrators are so removed from what it's actually like on the ground that they just have a very hard time comprehending. I had several people tell me that, they have a lot of people with MBAs, but not necessarily clinical experience who know what it's like. And so I think just really, really listening to your staff, and not just, which I see this happening not just in healthcare, but everywhere, where they have this sort of token listening, like, oh, let's have a meeting and share your concerns, and then nothing happens. And then next week there's a pizza party, but
Right.
I think really listening and then really making changes, which everyone's afraid of and nobody wants to do. But I feel like unless some real fundamental changes are made, there's going to be a real crisis in healthcare. And that was, yeah. And the pandemic has kind of made that obvious, but I think people still don't get it.
I think you're right. Yeah. Yeah, it is. Yeah, it's very, very serious. And when I said at the start that how we handle codes is badly, is that every time we had a code when I was working bone marrow transplant, we never had any kind of debrief, not even a clinical debrief. Like, why did you call the code? What were you thinking? Is there anything we could have done better? Nothing. We didn't get feedback from the intensivist unless the doctor who ran the code felt like we'd just done really badly, and then we would get some kind of random criticism. And I really wanted that, because you're doing your best when you call a code, and to not get any kind of even clinical feedback, much less emotional, like, how do you feel that this person who you thought was stable, you walked into the room and their oxygen was 60% and they were blue, and now they're back in the ICU and the daughter's in the hallway crying, and after one code, one of the chaplains came up, because you said they can really help with this. And somebody had put a program in place where the chaplain would talk to us, but I had no time to talk to her. So it felt like one of these, cruel things that my hospital would do, like set up a program, but it didn't really work for anyone. It wasn't really there to be helpful. But talk about, you have so many examples of creative things people have done to help with their grief. I know there's the pause is a great place to start. Yeah, let's let people know there is hope out there.
Yeah, there are some people doing great things. Jonathan Bartels came up with the pause, which is basically just taking a moment of silence, after someone dies, to honor their life and the fact that you were all coming together to try to save this person's life. And just doing that, even if it was just 1 minute, and it's a moment of silence, the way that he does it and that other people have adopted it. And it just gives people an opportunity, however brief, to just kind of mourn that life and celebrate that life and honor that life. And just that does have a huge impact. There are a lot of other creative ways, like you mentioned, that people have found to kind of address these difficult feelings that come up. So whether they're personal things like that they do on their own, like journaling or exercise, or that they do in a group, like there's been music therapy or hula hoop therapy. These are all great, but then, like you mentioned, unless there's actually the time available to make use of them or to do them well and properly, or even to just take a day off, because sometimes that's what's most needed. It's great to have like a 20-minute yoga class, but if you can't take a day off, then it's just not, maybe that's what you need. And if you can't do that, it's going to just have widespread repercussions down the line. So I do think that there are a lot of times when healthcare organizations will come up with these things and then say, look what we're doing, but it's simply not enough. Yeah.
Yeah, that's a great point about taking a day off. And I loved it when you talked about that. It sounded like physicians, once they were done with training, it was easier for them to do that. Although that's probably not true across the board. It probably depends on your hospital and your specialty and and all kinds of things. But yeah, I had a nurse friend who woke up to go to her morning shift and was just vomiting and stomach cramping. And she said to her husband, well, I can't call off, like just,
Yeah. Yeah. I have healthcare worker friends too, and they go to work when they're sick, and it's like, that doesn't make sense.
yeah. And I think the public doesn't understand that incredible pressure to show up. And you're right, it is a very militaristic idea of, we're on the front lines, we're fighting the battle. Like, no, we're not fighting a battle, we're trying to help people.
Right, right. And then you look at the mental health of our military veterans, and it's like, well, of course, if that's the kind of, you're going to this traumatic situation, this violent, difficult, challenging situation, and then you're suppressing all the emotion that comes with it. And then what do you come home with? You come home with all this trauma, unprocessed trauma. So, um, yeah, I really admired in your book the fierceness with which you advocated for yourself. I thought it was really wonderful, as you mentioned, wanting to hurt that woman, which, of course, is not a pleasant emotion to have, but the fact that that motivated you to really advocate for yourself in a way that worked in many ways. So I thought I'd love to hear more about that, both for the benefit of patients, but also in terms of how clinicians can learn to advocate for themselves in their work environments, because I feel like they're always so much better at advocating for their patients.
That is so true. And it's very true of nurses. We will go to the mat for patients and then say, well, yeah, I didn't take lunch and I'm supposed to be paid for that time, but I don't really need to be paid. I had this transition that I outlined in Healing from trying to be the quote unquote easy patient, because as we've said, healthcare is an assembly line, and it's not just one assembly line. There's the breast cancer assembly line, then there's the billing assembly line, then there's the discharge assembly line. And if you put the brake on your assembly line, well, then what's going to happen to all the other assembly lines? Nobody likes that. So we just want everybody to be the go along, get along patient. And I own up to this, even though it's kind of painful to admit that. But I realized this is not working for me. I'm going to speak up. I'm going to push back and say, why does this have to take so long? Why can't I get an answer? I don't understand what you're saying to me. And at some point I have this self-realization where I say, oh, I am the difficult patient, which again, I have used this label. I am somewhat ashamed to say, I've used this label to describe human beings. But I realized that the difficult patient, and I use that term on purpose, the difficult patient is actually being very appropriate. It's adult. It's certainly normal to say, I don't understand. Please explain this to me. Why do I have to wait 3 weeks for this? Can't we do it sooner? To really push back against that feeling that you're just hitting a wall, and that wall you're hitting is people saying, I've just got to keep moving forward. I've got to keep the assembly line moving. And I don't think they want that either, but it is possible to intervene in that. And for patients and loved ones listening, I really want everyone to start doing that more, and own it as, I am entitled to understand my health care. I need to know what these medications are that I'm being given. And if you're dealing with a physician who's rude to you or won't explain those things to you, and that was a Freudian slip, and you have options, try to find another doctor. I mean, healthcare needs to be respectful. And the thing that really struck me during my treatment and when I was writing the book is that I got everything I wanted in radiation oncology. And this was in the basement of the same hospital where the scheduler had left at 2:59 and nobody, no one else but the scheduler can schedule an appointment, right? But somehow in radiation oncology, it must have come from the leadership, but they explained things very clearly. They made the expectations clear. This is what we want from you. This is how long it's going to take. I went there 5 days a week for 4 weeks, every single day. The text, "Hey, Theresa, how you doing?" And they were that way with everyone. And one of them said, "We know you don't want to be here, so we have to be extra nice." And these were people, when they were really busy, were sometimes they were working 12-hour days, and they would say, "It's really hard, we're really busy," but they didn't take it out on the patients. And so in that small department, they, found the secret sauce, or whatever you want to call it, that allowed clinicians to see patients as human beings and treat them that way, and at the same time see themselves as human beings and have their own humanity be supported by their workplace. And it did not seem complicated. That's the thing. It was being polite, being clear, being civil, being on time, really, really exceptional, but at the same time, what should be ordinary in a lot of ways, right? So the question I ask in healing is, well, if they can do it at radiation oncology, why can't they do it everywhere else?
Right. I thought that was a really good question.
and that's maybe a good segue, because I know so many people you talk to use meditation and self-care and tried to promote their own personal resilience. And my problem with that is I've seen self-care kind of used as a weapon against nurses, like, "Oh, you're stressed out. Well, are you doing self-care?" As if, there's no self-care that's going to help you when you have twice as many patients as you can manage. So if you don't mind reading that part of your book I had selected, is that?
Yeah, I have it here.
Because it's such an important question. How do you balance personally helping yourself with what's going on in the system? How do you think about that? It's difficult.
Right. And what's interesting is the part that you mentioned is really about people who've left the system because it doesn't function for them anymore. And I feel like that's kind of where, we're heading, because unless things change, that's more and more going to happen. And yeah, like you said, it's true. If there's not the opportunity to actually practice these things, then they don't have any value. So yeah, Theresa asked me to read from page 123. And this is based on an interview with Pamela Weibel, who's well known as a physician mental health advocate. So Weibel began leading retreats for physicians looking to launch an independent practice, many of whom had also become suicidal. She realized the extent of the issue after asking physicians at a business strategy retreat how many of them had lost a colleague to suicide. Everyone's hand went up. Next, she asked how many had been suicidal themselves, and only one hand went down.
Oh.
The number one main reason for many people is either a huge level of disillusionment to the point that they end up suicidal, she said, or sort of that slow progressive irritation from being in the wrong hazardous working environment over time that will wear on your soul and make you feel like you're just going through the motions. These days, Weibel holds retreats for individuals as well as groups of up to 50 people, though she's leaning toward more frequent, smaller retreats at various locations around the country. They still cover business strategy, but because she's gained such a reputation as a physician mental health advocate, many who attend have been suffering from occupationally induced mental health conditions. People are coming to receive help and healing from the trauma of their medical training and being trapped in medical practices that are really crushing to their hearts and souls, said Weibel, who would like to see physicians granted the same labor rights as others in terms of their mandated hours and breaks. And so we end up having to spend half the retreat, at least the first day, helping everyone to get rapid, quick healing and validation. From there, she discusses what physicians wrote on their personal statements when they first applied to medical school, and then explores what their ideal clinic or working environment would look like and helps them take steps to realize that goal. Weibel says that while medical students, nurse practitioners, and physician assistants have attended, the majority of her participants are doctors, even some in their 70s who are looking to establish a practice more in line with their values before they retire. Around 90% of participants have taken steps to open their own clinics, she said. Those who remain in the traditional medical model, meanwhile, must continue to find ways to navigate the challenges inherent in the system through personal self-care practices, mindfulness, and other tools while advocating for institutional reform. Although there have been some encouraging shifts in approaches to medical education and training based on the Stanford model, the healer's art, and other innovations, these have not been enough to stem widespread depression and burnout among healthcare workers, both in the educational system and in healthcare at large. As a result, clinicians are largely left to find their own ways of dealing with the mental, emotional, and physical strain. For some, like Weibel, that means opening their own practice. For others, it can mean leaving the profession altogether. Many develop unique and creative means to retain their sense of empathy and compassion and to establish a greater sense of harmony between their work and the rest of their lives.
Yeah, it's hard. I want to point out for people reading the book in that selection, well, first of all, you see how Rachel's able to so well bring these issues together that are clearly in conflict, and also give you ideas. The book is full of ideas of things that can be done to help staff with their feelings that are not pizza parties. But also, if you feel like I'm not seen, I'm burnt out, nobody understands that, you will find yourself in the book also. So it's a really masterful job of balancing, wow, we have this huge problem, and also there are people trying all kinds of different ways to manage it. And yet also there are a lot of systemic issues that are equally as huge, and how we're going to tackle those is, that's a big question. I mean, we know how to do it. It's just the people who should be willing to are not able to. I think now let's go to questions, because one of the questions actually piggybacks on what you and I just talked about, and I'll read them. So many of the suggestions we get for dealing with burnout are things like learn to meditate or do yoga, but this puts the onus on the individual instead of the institution. How can we work with administrations for programs that actually work? How can healthcare professionals like home health aides, who may not have the same sense of community support as nurses or hospital staff, build support systems? And before you answer it, I want to say another strength of the book is that Rachel looks at everyone: home health aides, environmental services people, acknowledging that all these people bear grief and trauma from healthcare, and the well-being of all of them matters. But to get back to the question, how can, say, home health aides build a sense of community support, build support systems?
Yeah, when it comes to self-care, I think it's really creating the time for it to happen. And I think, again, that comes down to, I talked to some places where it seemed to be sort of working, and it's because they set aside a day, they gave all their staff the day off, and they said, now we're all going to do this together. So that's community building, and it is providing self-care, and it's paying, they were paid at the same time. So it's providing paid time off.
Wow. Okay, where is that? Because I'm going to apply there right now. Yeah.
They're going to get inundated with applications. Yeah. But yeah, that's what's needed. And actually that was in the course of a study that happened, to see what do these healthcare workers need, what works. So as a part of the study, this happened. But they wanted to continue it once the study was over also. And I think that's the kind of thing that's needed. And I think healthcare organizations are very afraid to invest money in their employees, which seems very crazy to me, because turnover and replacing employees is so much more expensive. And so that's really what needs to be done. And also, I think just taking the profit motive out of healthcare to begin with seems like the most obvious place to start, and I don't understand why it hasn't happened yet. But I mean, I do, but I logically can't quite take in that it hasn't happened yet. I actually grew up in Canada. I'm from Canada. And so to me, it's
Okay.
extra absurd. But yeah, I feel like that's the first step. And you talk about in your book too, you took some time off to deal with your illness and then coming back to a for-profit hospice, which was very different from what you'd been working in before. And I found that to be really powerful. You had your gas mileage money taken away. The inpatient hospice center was closed because it wasn't profitable enough. So just mixing healthcare and profit doesn't make sense. It's not going to serve patients best. It's not going to serve clinicians best. But as long as that's the system that we have, I think individual healthcare organizations need to realize that they're not doing themselves any favors if they're not investing in their staff. And so hiring break nurses, hiring scribes, giving them days off when they need it, allowing a certain number of mental health days, and not creating a culture that doesn't penalize that, even if it's allowed. I think there's still a stigma. And so really giving the message that it's okay to do this. It's okay to take a day off. We encourage you to do this, is really necessary. And I think the same thing is happening right now around the stigma with mental health care, with the Lorna Breen Healthcare Providers Protection Act, which is requiring the Department of Health and Human Services to fund organizations, provide grants for encouraging mental health care, but also requiring them to send out the message that you should seek mental health care. It's important to seek mental health care. So I think the messaging is important, and then also following through without, not having everyone, when you come into work the next day, be like, oh, there's the nurse who took the day off, and
Yeah.
that's
How's your mental health now?
exactly. And I understand that everyone's understaffed. That's an issue, but it's only going to become a worse issue unless we start doing some of these things. So, yeah.
Right. And people listening may not know this, but there's supposed to be parity, PARITY, in payments for non-mental health care. I don't know what physical health care and mental health care. And just the fact that they're divided like that tells you something about the stigma, is not just in medicine, but kind of all over just the structure of healthcare. A lot of places have not done that. So there were nurses during COVID who wanted to find therapists, and then they found out that their health insurance wouldn't pay for them to see therapists. But that is coming down the pike. That is going to be put in place, and let's hope that and the Lorna Breen Act and will actually make a difference. Yeah, great answer. So this is now switching to you. Another question was, in what ways, if any, have the interviews and the process of writing the book affected your personal life and or changed you? And I'm very curious about this myself.
Yeah. I mean, it felt like it was challenging to be like absorbing all of these. I feel other people's energy, or I don't know, situations or feelings a lot. And so it was definitely challenging to be immersed in these interviews, but it also felt like such an honor. It was such a challenging time for everyone. Yeah, for people to be revealing their very vulnerable stories in the way that they did. And to be the recipient of those stories really felt like such an honor. And especially at this time when, everybody wanted to do something, and so few of us had the opportunity. It really felt like a gift to be able to do something. And actually, I was very touched by all of the chaplains that I interviewed, starting with the very first one I spoke with for the article. And I'm actually I don't even know if others on the call know this, but I'm going back to school in September to get a master's of theology and become an interfaith hospice chaplain. So.
Oh my gosh.
Yeah.
That's wonderful.
Yeah.
Well, lucky hospice. Oh,
Yeah, thank
congratulations.
you. I mean, I
That's
plan to continue writing. It's my first love, and I always will love writing. So, but I always am looking for meaningful work that I can do in addition. And so this seems like the next right thing.
oh, wonderful. That's well, we'll look forward to maybe a book about that, which would also be wonderful. Okay, the last question I'm going to read. How can we get this book to medical students, and I would say nursing students, to read before their first day of med school? Had I read this before entering medical school or nursing school, it wouldn't have prevented me from becoming a doctor, but it would have served as a guide on what to expect, and I would have referred back to it at different points in my career. Such a great point. There's a huge hole in medical education that this book fills. And I'm not just saying nursing to plug in nursing. That's completely true in nursing. I mean, we're taught the same. You're invulnerable. You don't need to sleep. You know, if you're what was it they always said? If you're early, you're on time. If you're on time, you're late. And if you're late, I don't, you know, it was like so terrible. They wouldn't even say what the consequence was. So, you know, all this pressure about putting these unreasonable expectations on yourself and not having any needs of your own.
Mhm.
But yeah, how do you know, what do you have to say about that? Besides the fact that you would love every nursing and medical student to read your book. Yeah.
I mean, I do, yeah, I do think it's important. I think that people go into the field not knowing, and I had some other people I spoke to make this point. They go into the field not knowing what they're going to be confronted with, and maybe to the point where they don't even think about it when choosing a specialty. You know, like maybe you shouldn't choose this specialty if you have trauma in that area already, or, you know, just thinking about the emotional aspects of what you're getting involved in from the beginning. So when you get there, which you're going to get there, you have some tools and some idea of what to expect, and the fact that you're not the only one, because I feel like that is the main challenge, is the message that people get, that if you're suffering this way, you're the only one. And I think that's what leads to the suicides and all these other substance abuse and all these other very difficult and ineffective coping mechanisms. But yeah, in terms of how to do it, I don't know. I mean, I guess just I hope that the people who need it will find it. I hope. Yeah.
Yeah. And if to get the word out about how tough it is, how tough medical school is. I have a friend who's in medical school right now, and I thought I knew what it was like, but I mean, she's much younger than I am, but you know, it's really hard. It's very hierarchical. She, you know, does not feel supported as a student. They're constantly being evaluated, and every single evaluation feels like their success or failure is on the line. I mean, that in and of itself is very, very hard. And then they're dealing with all this sad, traumatic stuff, as you say.
Yeah, I think it comes back to what you said about radiation oncology too, and how you feel that it was really a leadership thing that was making it work. And if that kind of leadership was existent, and if that, and it does in some schools, you know, it's there, or at least in some small parts of some schools, in nursing schools and medical schools. But if the leadership was there that actually addressed these issues and encouraged people to speak about them, and then also didn't, you know, overburden students with things they don't need to be overburdened with, which is kind of the way that it's approached for reasons that don't really help anybody, I don't think, then I do think that would make a big difference. But I really think that's an important point, the leadership issue, and really thinking about what benefits are, why are we doing these things? Is it because, like, why is our culture this way? Is it because it benefits, you know, our clinicians
Mhm.
and the patients, or is it just the way we've always done things? And because it's it makes us feel like a cool aviator or like hero of some kind. Yeah.
Right. It's
I was
a
thinking of Top
failure.
Gun in that moment, which just came out again. Yeah.
It's right. Not even just sort of willful, I was going to say sadism, which is probably a little too strong, but,
Yeah.
maybe it's just a failure of imagination. Well, how else would we do this? Well, fairly, and,
Yeah.
and hoping that you wanted people to succeed, because certainly, yes, nursing school can be the same way. Although I give lots of talks at different nursing schools, and I've been to nursing schools where there's just such a positive feeling among the faculty and among the students, and they clearly have such caring for their students.
That's
And
wonderful to hear.
yeah,
Yeah.
I think it really does come a lot down to leadership. It feels really good. You had asked me to read something, and I was thinking,
Yes.
I'll read this, and then you can riff on that. Yeah, so here's the book again. This is product placement, everyone. Um, so this is Healing is a series of short chapters that alternate between me being a patient and me being a nurse. And my son, who's 25, read the book and he said, "Oh, first that really annoyed me." He's very kind, but he will absolutely say what he thinks. So he's like, "That annoyed me." And then I realized that was probably how your mind was working. And I said, "Yes, okay." But this is a chapter where I'm feeling like, wow, I'm really a patient now and what's going on. So modern healthcare saved my life, but Theresa, the person, got lost. We discuss physical failure in healthcare in terms like decompensation, morbidity and mortality, multiple organ dysfunction syndrome. Again, talk about distancing from the human, right?
Yeah.
And the patient ceased to breathe. But what about the soul, or whatever one calls that singular essence that makes each of us who we are? That needs tending too. All I wanted after my diagnosis was for someone involved in treating my cancer to sit down with me, look me in the eye, and explain my diagnosis, discuss what my prognosis looked like, and clarify my likely course of treatment. That's it. Simple, easy, never happened. Another fulcrum, the separation in healthcare of patient and person, body and soul. No one helped me make appointments. No one talked about how long treatment would likely take. No one told me we can treat this. That is failure. And when I felt this failure, felt it hurting me over and over again, I knew that it was also my failure as a nurse. It is a failure of compassion, which is not surprising since over the past 2 decades, healthcare has changed from people-centered to profit-centered. Profit makers focus on revenue, not feelings. Diagnosis-related groups and the International Classification of Diseases 10th revision billing codes do not address a clinical lack of compassion, but slighting the human in patients and clinicians alike shows we've got the balance wrong. Can we try again? Why not? People failed me when I was a patient, and I failed patients when working as a nurse. I see that now. People also came through for me, and as a nurse, I did my best for patients. But the overall balance between profit and compassionate care is off. It has tipped too far towards profit. Consider that more than 25 million Americans lack health insurance. Medical mistakes are one of the leading causes of death in the United States. Life expectancy in the US is going down, not up. America spends more money on healthcare than any other industrialized country, and our outcomes overall are much worse. These data points show how little patient well-being matters relative to the money-hungry healthcare machine. We can try, though, to restore the balance, to find that synergy by caring equally for all patients. by treating the body and the soul.
Yeah, I really loved that section because it weaves your personal experience together with the whole systemic issue of lack of compassion.
Thank you. But I want you to have the last word. And how do you put what you discovered and learned about in connection with what I just read and this idea of a compassion deficit that we're all suffering from?
Absolutely. And, it really struck me, and I loved the way our books complemented one another as well in this regard, because you were writing mostly from a patient's perspective. And I was sharing the perspective of healthcare workers, but they're saying the same things, which is that there's a lack of compassion. And so for patients, they're experiencing a lack of compassion from their providers, but then the providers and the other clinicians are just unable to provide the care that they want, the compassionate care that most of them want to be providing in the first place, because of all of the systemic problems. So the lack of time, the assembly line, just the inability to spend more than 15 minutes with a patient. Like, how can you, even just communicating those basic things, like you said, is just providing the time and the space so they're not so harried that maybe they haven't moved on to the next patient yet, but they're probably already thinking in their minds, what is the next thing I have to do? So just creating a little bit more space around these things would make such a huge difference for both patients and clinicians, I think.
Yeah, it doesn't have to be that hard.
I agree. We make it much harder than it needs to be. Like most things in life, I feel like we do.
Yeah. Is there any final thing you would like to say after I make this final pitch about your book that really is so important, especially coming at the wake of COVID, because this is a great time for a reset. Let's have a healthcare reset. Let's really rethink how we pay people, our expectations of them. Let's value the people who work for us. And there is even research that shows compassionate care actually saves money because people are less quote unquote needy and demanding, and even things like they'll report less pain after surgery, which is incredible. So yeah, if you could leave everyone with one concluding thought about your book, what would that be?
I might kind of go from something you just said, which is, I think you're referring to compassionomics when you mentioned some of the research which both of us quoted in our, in our books. And one thing that the authors there mention is that they say that empathy is different from compassion in that empathy is a feeling and compassion is action. So you have the empathetic feeling and then you take action. So I think I would just want to relate that to where we are now in healthcare, which is that we need action, and everyone's hurting, everyone's feeling it. The clinicians are feeling it, the public's feeling it. But what we need is action. And I don't know about you, but I have not seen enough in that regard at all. So, yeah.
Right. And right. So fingers crossed.
Yes.
That we get that, because we need it as a country.
Yes.
And in the meantime, people should read your book.
Wonderful. And please also read Healing, which is such a lovely book and so well written. So I'm a writer at first. And so I really, and I know you are too, you still have a PhD in English. So yes, I really appreciate good writing, and it's just a beautiful book.
Thanks.
Well, thank you so much.